When we were meeting in person, one of the highlights was to actually have everybody introduce themselves and the programs they're working on. In the interest of a Zoom call and an expected attendance of about 80 people, we want to modify that today and ask if you would go to the chat box and just put your name and organization. If you have something important you want to announce, put it in the chat box throughout it. Also in the chat, but we will also have a very quick 3-question survey at the end where we'd like your feedback on the materials we've shared today, how to make those available, and any suggestions for topics you want to be sure that are covered or other speakers that you've heard that you think would be a benefit to the community. So with kind of that as our group introduction, I'd like to turn it over to Laura Dwire, the Community Programs Manager at the St. Joe Foundation, who's been working very hard on the Sleep Safely campaign to kind of give you an update on what that is, and then we'll get into the regular program. Laura?
Good morning, everybody. Wow, 3 pages of faces. How exciting is that? I hope you're all staying warm and safe. I almost fell just taking the trash out today, so I hope none of you experienced that as well. Very excited to talk about Sleep Safely today. Mark, did you want to bring up the slides, please? As you remember, the Sleep Safely campaign, we had 2 goals. One is that all Allen County infants have a safe place to sleep, and that all Allen County parents are educated on safe sleep practices. So the purpose has been, you can go to the next slide. Sorry, Mark. Next one. There you go. The purpose is, I have to preface this with telling you that it is not a crib giveaway or a pack and play giveaway campaign. What this is to create a community-wide message on safe sleep. Again, we want all infants to have a safe place to sleep. So we're doing that through the 1-page flyer that has been created. And Mark's going to put a link to that in the chat box for all of you. And it simply is the ABCs extended a little bit. And so we're hoping that everyone agrees to spread the word through our flyer. We also, through partnership with the IU School of Medicine, our partners have agreed to share data and collections so that we can get information from Northeast Indiana and from Marion County on safe sleep best practices and really what's going on. And then again, we'll have safe sleep education and resource referrals. So we do want all our infants to have a safe place to sleep. So we need to make sure that they connect to resources that not only do the education, but then also distribute pack and plays or cribs. Next slide. Thank you. So we're doing this through partners, all our community-wide partners. And again, we're just building upon the great work that they're doing now. These are partners that are already doing education and also doing referrals and everything else. So all we ask simply for our partners is to agree to, this is not a binding contract by any means, agree to conduct safe sleep education for their clients and families, circulate the 1-page handout at community-wide safe sleep with a safe sleep message, enroll and certify safe sleep ambassadors. So this is, anyone can be an ambassador. So if you just take this free online training, you'll have enough education to circulate or disseminate the information, but also just to have a conversation. So we're hoping that we have daycare providers, daycare centers, Christ Child Society, Baby's Closet, anyone who's volunteer or working, that they have a knowledge of safe sleep practices. Now we ask them to collect and submit the survey data, as I mentioned before. And then again, connect clients with community resources so they can have cribs and pack and plays in their homes. So next slide, Mark, sorry. So far, we've got these partners, and again, they're already doing education. They're already doing great work, but they have signed agreements. So Hope Center, Early Childhood Alliance, Healthier Moms and Babies, LSSI, Macmillan Health, Neighborhood Health, and a Women's Care Center. DuPont and Parkview are going to join us as well once it runs, obviously, through their legal department. So that's kind of an update. We're going to launch this probably officially, I would say, in March, where we'll start collecting the data. And then at our next PIC webinar, which is May 20th, we will have data for you and an update plus speakers to just talk to you about SUIDs and other things on safe sleep.
Thank you, Laura. That's helpful. And stay tuned. We'll be sharing with you what we learn and from all of this data. And we thank everybody and anyone else who wants to participate by contributing data. Please feel free to reach us and we'll get you connected with IU School of Medicine, who is really doing the heavy lifting on this project. Now, what you all really came to hear is I guess really the findings from the Indiana Maternal Mortality Review work that has gone on. And I can tell you that I am very looking forward to this, because when I heard from several people what a great presentation it was at the Labor of Love conference in December, that they were surprised how much they learned, and they were very well-informed people. We were very excited that we were able to bring it to you all today too. So I'm going to turn it over to Kelly Cunningham with the Indiana State Department of Health to really, if you could introduce this body of work, Kelly, and kind of set it up and share with us what we need to know so we can be more effective keeping our moms healthy and safe.
Sure. And I actually have a team with me today. So we have Abby is our epidemiologist, and Christie is one of our nurse abstractors. And Dr. Abernathy actually is the chair. She's with us as well. And we have local representation. So one of the things that we do pretty deliberately is we structure our Maternal Mortality Review Committee membership obviously based on disciplines. So we've kind of run the gamut from social work to obviously clinicians, cardiology, nurses, and all the way down to Kevin Hunter up there in the corner, in my corner is law enforcement. And we also pull geography. So it's a very representative group. So we've got folks that kind of come from the four corners to participate. So MaryClare, Captain Kevin Hunter, and Kathy Detweiler are all on here with us as well. And so we'll kind of chunk this presentation up, and we were hoping that they could kind of let the group know some of what they're doing as we get to the recommendation side and how this all ties into you guys locally. Dr. Abernathy, I see you. Do you want to do a little intro before Christie kicks it off?
Sure. I want to thank you for letting us give you this information today. This is the first report from the Maternal Mortality Review Committee. It was formed in 2018. We have gotten the first full year's worth of data, and we wanted to make sure we disseminated that widely as we can. So I appreciate you allowing us to present this data to you today. So go ahead, Christie.
Beautiful.
There you go.
Okay, so Christie, if you are able to cut in, otherwise I'll go ahead and get started. So go ahead and advance. This is our kind of boilerplate language for the State Department of Health. You can go ahead and advance that as well. So why the maternal mortality review piece is kind of critical is we know that a lot of moms have a lot of touch points, or should have a lot of touch points during her pregnancy. And basically what we're also finding is gals don't necessarily, a lot of times are not really consistent on well woman care. So their access to OB or prenatal care is kind of like a really, it's a really big point for interactions, for identifying chronic conditions that we may or may not otherwise have. So, oh, Christie, are you there?
Yeah.
Okay, she's gonna go. Go, girl. You got it.
I am sorry. I don't know what happened.
So part of our group, again, is myself, and then Abby's the epidemiologist who will actually do the data. And then we have the nurses who you can continue to share, have clinical bedside experience, and they're the ones that really dig into the records and create these case narratives for us. So Christie is one of those dynamic duo. So take it away.
I could hear everything when everybody was talking at first, then all of a sudden the sound went out. I saw Captain Hunter waving and I saw MaryClare waving, and then everything was silent. So
Yeah,
I
I'm
have
super
no
glad
idea.
they're recording this too.
I have no idea what anybody said, but I was so excited to see everybody. So hi, MaryClare. Hi, Captain Hunter. So I missed it. Where did you leave off? I'm sorry.
Go to the next slide, Mark, and then just pick it up from there.
Okay. We are talking about maternal mortality as the death of a woman during pregnancy or close to the time of pregnancy. Okay, so this is talking about how in July of 2018, Governor Holcomb signed legislation that requires the state to have a multidisciplinary maternal mortality review committee. And that is talking about our committee, what we do. We are reviewing all of the deaths, and it is our goal to determine risk and protective factors that contributed to the deaths, both pregnancy associated and related. That is our goal, so we can stop it from happening again. You can go to the next slide, please. These are our definitions. A pregnancy-associated death is a death of a woman while pregnant or within 1 year of the termination of a pregnancy, regardless of a cause. A pregnancy-related death is the death of a woman during pregnancy or within 1 year of the end of the pregnancy from pregnancy complication, a chain of events initiated by the pregnancy, or the aggravation of an unrelated condition by the physiologic effects of the pregnancy. Pregnancy-associated but not related death is the death of a woman during pregnancy or within 1 year of the end of the pregnancy from a cause that is not related to the pregnancy. So if you look under that big umbrella, the pregnancy-related deaths, those are the ones that are directly related to the pregnancy, like if it was a postpartum hemorrhage or a peripartum cardiomyopathy. The pregnancy-associated or not related. That would be like if somebody had a car accident or they died in a house fire. And then sometimes we have the deaths that we just can't determine what the cause was from. For the last one, you can go to the next slide. The measures of maternal mortality, if you look at the definition, the World Health Organization only goes 42 days out from a pregnancy, and that is a little different, as you'll see on the next slide. And this is from any cause related to or aggravated by the pregnancy or its management, not from accidental causes. And then if you look at the next slide, you can see the CDC went a little further in depth and they termed it 1 year out. And again, they don't count it from accidental or incidental causes. This is from any cause related to or aggravated by the pregnancy. But we also are looking at other records. We are looking at vital records. We're looking at autopsy reports. We're looking at the death certificates. And with our maternal mortality review committee, we are looking at all of the cases, and we're looking a little more in depth. So this is why with our maternal mortality review committee, we're taking a more in-depth look at everything. And that's why I'm going to say ours is better. We're more accurate. You can go to the next slide. The maternal mortality review committee data. While pregnant or within 1 year of termination of pregnancy, regardless of the duration and the site of pregnancy from any cause, the pregnancy associated maternal mortality ratio. I'm sorry, the data source is medical and social records for the woman, as well as maternal mortality determined relatedness. So again, the Maternal Mortality Review Committee is determining the relatedness of these deaths. So when we're talking about data comparisons, it's like we are cautioning you to compare. We are comparing, it's like we don't want you to compare. I'm sorry, I skipped a slide on my thing. I'm sorry. As a result of, you can read the bullet points there, but the MMRC was able to determine how many deaths were pregnancy related versus overall pregnancy associated. This is our maternal mortality membership. We've got a multidisciplinary team. We've got a great committee. We meet monthly. We are looking to get, this is our 2018 data that we just put out. We will be done with the 2019 cases, and we're aiming to be done in May or June. We've got doctors, midwives. You can see the list that we have our law enforcement officer there. Nurses, we've got, again, it's a multidisciplinary team, but we've got a wide range of people, and they work very, very hard to get this stuff done. You can go to the next slide. So in our meetings, we ask 5 questions with every case. Was the death pregnancy related? The next question is, what was the underlying cause of death? And sometimes the underlying cause of death that the committee determines is different than what was actually on the death certificate. So sometimes the committee decides it was something different than what was actually on the death certificate. Was the death preventable? Dr. Abernathy always says, who could have done what, when to change this? And then what were the factors that contributed to the death? So was there any, what was happening in the mom's life that contributed to this? Medical factors, social factors. Sometimes there's a whole list of things that are going on in her life that can contribute to that. And then what recommendations and actions, what can we do to address those? And then the process, the case identification, Abby gets a list from the death certificates. We get a list of cases. Abby goes through those. Then we get the case selection. So we compare, we look at the death records and compare them with the birth records. And we weed out those cases first to determine if they were actually pregnant or not. Sometimes on the death certificates, they're marked pregnant at time of death when actually indeed they weren't pregnant at the time of death. So we need to flush those out. Then it comes to abstraction, where Caitlin and I go through and make a timeline of what happened. And then we present that to the committee. That was the case review and the presentation. Then the committee goes through all those questions that we just showed you there, and they make their recommendations. And then we enter all of that data into the CDC database that's known as Maria. And then it goes through for data analysis. Now Abby's going to talk to you more about the data part of it.
Thanks. So case identification is really that first step. It's the first way we even capture our cases. We really got into the weeds there with the different ways that maternal mortality is defined by the different agencies, whether that's WHO, whether CDC's PMSS data, or whether there's new MMRC. So we're going to get a little bit more in the weeds just for a minute so you understand why MMRC is different and why it really is a better measure of the true burden of maternal mortality in Indiana. So like that previous slide showed, historically, we've always depended on just vital statistics, so that would be just death certificate records. And there's a checkbox on a death certificate that indicates whether a woman was pregnant or recently pregnant at the time of her death. And then additionally, O codes and their causes of death would indicate that it was an obstetric-related death. So that's traditionally how we've collected records. That's still our starting point, and we pull out any of those death certificates. We also use, IHA has assisted us in identifying a few extra cases that they have in their system. Facilities are required to notify us if they have a maternal death that happens in their facility that they are aware about. And then this last piece, we actually added a matching process where we took all death certificates of women of a certain age group and matched them to all fetal death certificates and all birth certificates within a year of that death. And then we were able to identify more. So you see this flow diagram at the bottom where we started out with 90 potential cases. We're going to get into how we got into our 63 overall pregnancy associated deaths and then our 10 pregnancy related deaths. Next slide. So like I said, we use a bunch of different methods to identify our cases. And initially we just used our death certificates and found 60 cases just from death certificate coding. Ultimately, once we tracked down autopsies, medical records, coroner records, whatever we could on these 60 women, we were able to exclude actually 27 of them who had not actually been pregnant at the time of death. So then we realized there was really this gap using death certificate coding. So then we worked with IHA, we checked facility notifications, and then did that matching process. And we identified an additional 30 cases. So next slide. So that's how we got to our overall 63 pregnancy-associated deaths for 2018. So that's the cohort from 2018. Those are the deaths we reviewed for that first year, and that's the data we're going to be looking at in the next few slides. So starting, so we're going to be looking mostly at pregnancy-associated. So again, that's that overall umbrella term of any death within a year of pregnancy, regardless of cause. And then we'll get into a few specifics on our pregnancy-related deaths. So of our pregnancy-associated deaths, looking first at race and ethnicity, we see on the left, the majority of the cases that we saw and reviewed were among white non-Hispanic women, followed by Black non-Hispanic women, and then Hispanic women of any race. However, women give birth at different rates in Indiana, so we see more births to white non-Hispanic women. So it's really important to compare actually their rates to determine whether there's any disparity racially. So we see on the right that Black non-Hispanic women did have higher rates of pregnancy-associated deaths in 2018 compared to white non-Hispanic women, and then Hispanic women of any race had lower rates. I will caution that this is based on just 1 year of data. And so these rates are considered unstable, which means that comparisons year to year, they might fluctuate. So we'll have a better idea as we continue to collect data, whether this is the true disparity or if it's a different number. Next slide. We looked again at the same thing, looking at age of the woman at the time of death. We see the majority of these deaths are occurring to women between the ages of 20 to 34 on the left. But again, the majority of births are occurring to women between the ages of 20 and 34 in Indiana. So it's more relevant when comparing to look at their rates. So if you look on the right, we see women in their 20s had slightly higher rates than women in their 30s of pregnancy-associated deaths. And then women in their 40s and above had much higher rates. Again, these are small numbers. We will continue monitoring these in the next few years. And as the rates become stable with higher numbers, we'll really have a better idea of what the true disparities are. But this just highlights what some potential disparities are. Next slide. We also looked breaking down by education level. So looking on the left, we see 65% of these cases we reviewed had either a high school grad or GED equivalent or less of an education, and then only 17.4% had some college and 17.4% had either an associate's or bachelor's degree level education. And then on the right, we see just over half of these cases that we reviewed, the women were employed at the time of their death. Next slide. We also kind of looked at the general geographical breakdown. So we see the majority of these cases we reviewed came to were to women that had last resided in a metropolitan county. So that's defined as having an urban area of 50,000 or more. So 71.4% of our cases came from those kind of counties, followed by micropolitan. So those are that middle level. So they have an urban area with 10,000 to 50,000. And then smallest came from rural counties. Next slide. And then we also wanted to compare to OB Desert County status. So in 2018, IHA and the Department of Health put together this, this map of counties in Indiana, and those counties in gray were designated OB Desert counties because they either lack any hospital or they lack a hospital with inpatient delivery services. So of the pregnancy-associated deaths we reviewed, 11.1% of them came from one of those OB Desert counties. Next slide. And then this slide kind of breaks down the level of care that these women were receiving. So on the left, we really want to highlight early prenatal care. So that's defined as entry into prenatal care during the first trimester. Less than half of these cases that we reviewed, the woman had entered prenatal care during that first trimester. And then if we look on the bottom of that slide, we see almost a quarter of them had no known prenatal care at the time of their death. And then on the right, breaking down insurance status, we see over half of these women we reviewed were on Medicaid and only 20% were on private insurance. Next slide. And we wanted to break down that insurance level and prenatal care a little bit more. So if we look on the left, we see the percentage of maternal deaths where women entered prenatal care in their first trimester by insurance status. So 50% of the women on Medicaid had entered prenatal care in that first trimester, and 69% of women on private insurance entered prenatal care in that first trimester. So there's a gap there. And then on the right, we see the average number of prenatal care appointments that were kept by women, depending on their insurance status. So there were fewer average number of prenatal care appointments for women on Medicaid versus private insurance. And this could be due to a later entry into prenatal care. Next slide. This slide is looking at the timing of all pregnancy-associated deaths. So we capture from during pregnancy all the way up to a year postpartum. We see some deaths, 9 occurring during pregnancy, 4 deaths occurring on the day of delivery, 6 within that first week postpartum, 3 in that 7 to 42 days. But then the vast majority, almost 2/3 of these deaths we reviewed, occurred in that 43 days to a year postpartum. We really want to highlight this because previous measures have not always captured this 43 days to a year, and we see that the vast majority of these deaths do occur in that time period, so it is important that we keep capturing and keep looking at these deaths. Next slide. And this slide is just looking at those pregnancy-related deaths. So these are the deaths that the committee reviewed and determined that the cause of death was directly related or a consequence of the physiological effects of pregnancy. So if we look at the timing of these deaths, they are a little bit more concentrated towards either during pregnancy or that first week postpartum. We see 70% occurring in that time. However, we do still see 20% of those deaths we reviewed that we determined pregnancy related occurred in that 43 days to a year. So it's not just the non-pregnancy related or what we call pregnancy associated but not related. It's not just injuries occurring 300 days out. There are pregnancy related deaths that are occurring in that time period. So it is really important for us to capture all of these deaths. Next slide. This slide is looking at the underlying cause of death. So this is the overall pregnancy associated. All of those 63 deaths we reviewed, these were the top causes of death listed on their death certificate. And you'll see overwhelmingly accidental overdose was that #1 cause of death we saw. There are a few other injury-related causes up in that top causes of death, including motor vehicle collision, suicide, and homicide. And then we see some medical causes up there on the top as well. Next slide. And then this graph is breaking down, these are just our pregnancy-related deaths. So we had 10 deaths from that 2018 cohort that the committee determined were directly related to pregnancy. If we look at this chart, there were 10 deaths and there were 9 different causes of death. So we can't really get any trend information out of this right now. I would caution not to look at the hemorrhage being 2 and preeclampsia being 1 and say, okay, hemorrhage occurs at twice the rate of preeclampsia. We can't really say that right now. This is 1 year of data. These are very small numbers. But what we can say is that pregnancy-related deaths are happening across a wide variety of causes of death. Next slide. So in order to really quantify maternal mortality rate, it's important to look at not just the number of deaths, but the rate of death. So on the left, we're looking at the pregnancy-associated rate. So we had 77.2 pregnancy-associated deaths per 100,000 live births in Indiana in 2018. So again, that's deaths from any cause within 1 year of pregnancy or childbirth. On the right, we're looking at the subset of those that were pregnancy-related. So we had 12.2 pregnancy-related deaths per 100,000 live births in Indiana in 2018. And a reminder that those pregnancy-related is if it was directly related to pregnancy, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the effects of pregnancy. And this is where I want to pause and just give a caution that I think when we get rates, our first instinct is to want to compare them to other rates. Unfortunately, this is very new data for us, and it is very new data for some other states as well. So the CDC has not really released MMRC level data for all states to be able to compare. And these rates really aren't comparable to previously measured rates that just use vital statistics. So we really caution that these can't really be compared right now on a national level, but hopefully soon once more states are reporting regularly. Next slide. The next thing the review committee does is looks for contributing factors to the death. And the number one contributing factor we found was substance use disorder, and either definitely or probably contributed in 51% of those deaths we reviewed from 2018. Next slide. Followed up by mental health conditions other than substance use disorder. So these mental health conditions other than substance use disorder were determined to have definitely or probably contributed in 38% of these pregnancy-associated deaths from 2018. And there was heavy overlap between those cases where we saw substance use disorder and other mental health conditions. Next slide. The committee then determines whether a death was preventable. And so we found 80% had either good chance or some chance. And then overall, we decided that 87% of these pregnancy-associated deaths were preventable. In the next slide, comparing that to our pregnancy-related, so just that subset of pregnancy-related, 90% were deemed preventable. So overall, these pregnancy-associated and pregnancy-related deaths, our committee is saying, are mostly preventable. Next slide. And then Kelly, I believe, is going to be jumping in to talk about how we turn these data into recommendations at the end of each of our review.
Okay, so we're going to do this a little bit differently. So you guys are the first group that we've presented to on a kind of a more local level. We've done patient safety coalitions, and we've done, Alliance for Innovation of Maternal Health groups and hospital groups. But this is our first kind of pass at this really local work. And I know that you have some passionate folks at the table that have the capacity to do this work. So Kathy Detweiler is actually going to present the recommendations and then tie them a little bit more into the local stuff that you guys are doing. And MaryClare and Kevin, feel free to jump in on this as well, so that you guys can really kind of personalize this information for what Allen County needs or is already doing based on what the MMRC found.
Thanks, Kelly. Can you hear me okay? Okay. So none of the recommendations that you're going to see or that are going to be foreign to you. This is the kind of thing that we talk about every day, all day in all of our lines of work. I think the startling part is how significant they are in contributing to death. We knew they were problems, but did we know they were actually killing people? And that was, that's what I want to keep bringing home. So across the state, we know that we need to work with policymakers to have better information exchange among all of our providers. We, especially in the world of substance use and abuse, we talk about how fragmented information is, and healthcare providers have a lot of information. Law enforcement might have some information, mental health providers have information, and it's not easy to seamlessly share that information because of many layers of laws and regulations that make that impossible. We've talked about, actually I was on a call yesterday where we talked about the AIM bundles. The AIM bundles are specifically hospital initiatives aimed at reducing maternal harm. They talk about morbidity as much as they talk about mortality and having safe practices. Most of this group, we have a really good representation of community and hospital entities.
Kathy,
also-
can I ask you real quick? Can you explain to people what an AIM bundle is? I don't know that everybody knows.
Yep. So AIM is the Alliance for Innovation in Maternal Health, which is their logo is on the bottom. It is actually a group of professionals from maternal fetal medicine, certified nurse midwives, OB nurses, and obstetricians and gynecologists who all got together to put together bundles advising on best practices for maternal safety. So how we manage hypertension, how we manage hemorrhage, how we manage substance use. There's many evidence-based tools that are available to the public, or they're available to the public if you go on their website and Google it, but they're really geared at providing guidance for hospitals to implement all of the best practices. Does that help? Okay. All of us know that postpartum coverage for our uninsured or underinsured clients is a significant contribution to problems. So there are some significant stakeholders at the state level that are working to make sure that we can provide ongoing insurance coverage after 6 weeks postpartum. Next slide. We talk about the systems of care, and we kind of already mentioned the linkages between all of the different entities. One of the things that we found is the community services, for example, like DCS or family services, were involved in some of the scenarios, and we didn't get the moms to support. Sometimes we knew there was problems in primary care, or we knew that there were community resources available, but did we get all of the people to all of the right places when we actually could have? And the answer was unfortunately no. I want to say that I think this network that we have established in Allen County and the region is really a step in the right direction. I think we're doing a lot of the things that the MMRC wants us to be doing. And I think that's only going to get better because now we have some more recommendations from formal bodies and some active partners that want to work with us to drive down these numbers that are awful. Women who come to the emergency room don't get great follow-up care. They come to the emergency room, for example, sometimes with overdose. We didn't know that they were just recently pregnant. There's just a lot of balls that it feels like if we did a better job of communicating and linking the systems, we could actually provide wraparound services and we could actually save women and their families. Next slide. Specifically for our providers, we want to make sure that we're implementing the AIM bundles, that we're providing guidance to our obstetricians, gynecologists on some of the best practices that it's hard to keep up on. The nurses that are in discharging hospital patients need to make sure that everybody understands what the warning signs are and when they should come back, when they should seek follow-up care, or when they should call the doctor. Go ahead and next slide. Communities, again, this is kind of what we're doing. MaryClare, I want you to talk about some of this because this really talks about your expertise.
Sure. So one of the biggest things that you're hearing in the buzzwords that are out there right now are that we need to be trauma informed, that we need to do self-care, that we need to be culturally aware and also culturally humble in understanding the people that we are serving and also just how we are interacting in general. So a lot of the recommendations that we have come from a place of putting that lens on when we're addressing a patient's need. We had a couple of cases, just for example, if somebody had had a long history of substance use disorder, they might have in their community, and they were well known for that in their community, they might have had a different treatment path based on that substance use disorder because whatever was really going on with them was not the first thing that came to mind for the people that responded to that person's need. So kind of taking into account that we do have implicit bias in different situations, making sure that we can wrap our arms around patients and help patients understand why they need to have that kind of comprehensive support system outside of coming into the hospital, and they need somebody else maybe listening in on guidelines when they are leaving the hospital, if they're leaving the hospital without a partner after they've had a baby, then making sure that there's handwritten instructions, and that I know a lot of our hospitals are really great about highlighting, as they're discharging, they're highlighting the things that are very important to watch for, but also emphasizing with somebody that seems like maybe they have a language barrier, maybe they have an intellectual disability, maybe there's some other reason that they might not call in for help. Maybe they've traditionally been dismissed for concerns that they have medically regarding pain or regarding, elevated blood pressure or other things that they've been dismissed for based on a stereotype or just their own experience. So they're less likely maybe to call in when they have an issue because they don't want to be dismissed, or they don't want to be looked down on or looked at as ignorant or that kind of thing. So making sure that that conversation is open and that we're making every effort to encourage these women that are having babies and that are in our care to feel comfortable calling about any issues that they're having. I can give just a brief example of myself, just so that you have a good idea of what I mean by this. I am not at the BMI rate that doctors would love me to be at if I was having a baby right now. And I can tell you, if I was having, excessive back pain when I was pregnant with my little man, I was more hesitant to call in and complain of my back pain because I figured it was because I'm carrying a baby and I'm overweight, right? So if that is something and that would hinder, if there's anything you can think of that would hinder somebody from calling in, then taking into consideration that they do have those social constructs that are wrapped around them and these different points of our community engagements that might keep them from making that call, and that might end up with a traumatic or deadly event for them. We also want to make sure that when we are providing information or we're providing a resource for somebody, that can be a one-stop shop. Anybody that calls, my office, this mom might be calling because I'm at the Drug and Alcohol Consortium. They might be calling the office because their son is missing again, and they really want to get a resource on how to, get somebody to go to this place where they think the son might be when they're using substances. And you can tell that, I can tell maybe that mom's really breaking down and mom might actually need some care. So when they call my office, I'm not just going to tell them where they can go. You can go look up, you can call the jail, or you can go on the different criminal justice sites to see if they've been picked up for an OWI or if they've, been arrested and that kind of thing. But I'm going to also wrap them with the support of, here's some resources that we have in the community for families, because I know this is very hard for you too. So kind of that one-stop shop when we're talking about substance use, and we're talking about anything, we want to make sure that if somebody calls, that the person that's answering the phone, but also the people that are providing services are warm in that handoff if they feel like they need something else, if they need another service, and then it doesn't seem like an inconvenience. And I know that seems like a no-brainer, but I couldn't tell you how many times people have called in to different places and just, that's not my job, that's not my department, you need to get transferred here, and you get transferred 3 times before you hang up and give up. So that's just kind of another, like, the one-stop shop aspect that it kind of mentions it here. And then also just making sure that as a community, we and social service providers in the community, that we are identifying where the needs are and making sure that the resources are convenient and accessible to those people that have those needs. So making sure that there's family planning measures in place, that there's mental health care somewhere close by, that Parenting education maybe comes to you for the first 6 weeks after you've had a baby, because you're not likely to leave the house, especially in weather like this, you know. Maybe there's a video component, and if that person doesn't have access to internet or to a smartphone, that might be one that you make an exception for and make a call to the house. So that's kind of when we're looking at the MaryClare perspective of things, the social work and the social services perspective of things. That's really what we want to do. I think that one of the things we do, child fatality reviews, we do child suicide fatality reviews, we do overdose reviews, and we do maternal mortality reviews. And one of the things that is not common is it's not mandated that there's toxicology testing in any of these situations. So if the person that arrives on the scene can identify what the cause of death was based on their assessment, and they've identified that, there might not be a tox, might not be a tox screen on the decedent's fluids or whatever we call it. I don't want to, I'm grossed out myself just then, sorry. But we want to make sure that there's some kind of toxicology, because maybe somebody did have an accident and they slipped on ice and they slid into a tree, and that's why they, you know, had a motor vehicle accident and died. But maybe it also has to do with them having, you know, something to do with, you know, diabetes, insulin issue, or they had alcohol in their system, or there was some other majorly distracting factor that we could have prevented that death, and not just assume that it was based on, you know, the ice situation. So we talked about making sure that toxicology testing for just motor vehicle fatalities alone is something that is just an everyday, it's just a mandate. It's just something that we do to make sure that we're assessing that situation so we can prevent future deaths. So next slide. Okay, and so then the other, we kind of talked about this a little bit, but the other big part of this is that we want to reduce stigma surrounding women that have mental health and substance use disorders, or if their partners have mental health or substance use disorders. We can do this. We can understand things better. One of the best ways that we can destigmatize mental health and substance use disorder is by not identifying a person by their substance use disorder or their mental illness. So we talk a lot about person first language when we're talking about, if we you know, we have a person with an intellectual disability, we say a person with an intellectual disability. We don't say an intellectually disabled person. That's not what we say anymore. We need to work that into how we talk about individuals who have mental illnesses and individuals that have substance use disorder. And that is part of that destigmatizing, because you are not putting the onus of that disease on the individual themselves and saying that that is all that they are. So there's different ways that we can train our staff, that we can train our colleagues, that we can hold each other accountable in a way that will help have better outcomes for the patients that we serve. Also, just better awareness of mental health diagnoses. Captain Hunter can probably talk a little bit about what we're doing within the police department, but we want to make sure that when there is a crisis situation, that the people that are responding to that crisis situation are aware of the signs that there's a mental health issue at play, or maybe a substance use issue at play, and as opposed to maybe a deliberate aggressive act, or maybe there's an autism diagnosis or something of that nature that's impacting that situation. So there are different ways that we can help our community prevent these deaths in very small, everyday language, and just in the way that we are informed when we're coming onto a scene or into a room. So I can't talk about hypertension. That's not in my scope at all.
That's
so
one
I
of
will
those
let somebody else talk about that.
So we know that there are navigation programs. We have one specifically at Parkview. There are some home visiting programs that the state has partnered with to make sure that at a state level and at a local level, we are getting people to the community resources. There are certainly rural areas across the state where less robust programs. I think we're blessed in our region to have some great collaborative partners that do that work and make sure that people don't drop off. I think there's only one more slide, maybe two. We want to make sure that we and every one of us who works with patients, families, and are in the public are increasing awareness about intimate partner violence. That is still a significant contributor nationwide to maternal death. There is no less stressful time, or no more stressful time, I'm going to say, in a human or in a relationship than right after you bring a baby home. So I think that it's really important that people know how to get to safety if they need to get to safety, and identify red flags in relationships. And so we all, especially in this group, we all have a lot of patient contact. So we need to make sure that we're including those kinds of screenings and that kind of teaching into our work every day. And we all need to understand the challenges of maintaining recovery. Patients that, especially in substance use, relapse is a thing, and that we need to be able to support them and connect them to the right support services. Also, there were some significant Narcan or naloxone, we're not supposed to call it Narcan, is available, but does everybody know that? Does everybody know that Dr. Box already wrote an order? I can go anywhere and get Narcan, and do I know how to use it? Do I carry it in my bag? Is that a thing? We need to make sure that all families know that they have that availability, especially if they already know that they're dealing with substance use. All right, I know we probably went over our time. I don't know if you have any questions or comments, and I'll shoot it back to Meg.
Okay, I put out there, if anybody does have questions out there, you can put it in the chat box. You can just put your name in the chat box, or at this moment unmute yourself so we can get any of those clarified. And we have one more speaker we do want to hear from that I don't see anybody pushing anything in directly. And I don't see anybody from my view trying to raise their hand or anything. So feel free to put it in the chat box. But what I really would like to is we talk about the importance of pregnant women, new mothers dealing with substance abuse and addictive. He says, we've got a great new resource being put together in this community after a great deal of research by Macmillan Health. And so what I would like to do is turn it over to Nicole Fairchild with Macmillan Health to please share with us.
Hi, I'm Nicole Fairchild with Macmillan Health. I'm the executive director here. We have received funding after it's been about 1.5 years of researching and applying for funding, but I'll tell you a little bit of the backstory with this. So in 2018-2019, Macmillan Health received funding from the St. Joseph Community Health Foundation to conduct a community-wide assessment on the resources currently available for women with opioid use disorder. And we spent 6 to 8 months interviewing women with opioid use disorder, so pregnant or recently pregnant women. And then their babies, some of the women had babies with neonatal abstinence syndrome as well. So we put together a community report after interviewing 10 women. And then we also interviewed professionals at local hospital systems, and they had feedback as well. We released that report in 2018 called In Her Words. And it's a comprehensive report that's available on our website, and I can share that in the chat function as well. But from that report, it was determined that women with OUD would like to have resources other than maybe a trifold or a brochure or a handout, and professionals really didn't have much to give their staff or women that they were seeing with opioid use disorder other than these brochures or flyers, or kind of directing them around, like MaryClare mentioned, maybe directing them somewhere and then maybe they got pushed to different places. Essentially, what we found is that the women desired more education, but they didn't just want it in print form. They wanted it where they could easily access it from their phone, and have print resources available if they wanted them. So from that report, we decided that it would be best, and after asking these women, to easily access education on opioid use disorder, neonatal abstinence syndrome, mental health education. We have 10 different components that we're going to include. And it was determined that an app would work best for women as well as professionals. So we had applied to St. Joe to receive some funding to develop an app, and then found matching dollars to be able to move forward, and we received those matching dollars in December. So we are now able to move forward with developing an app for these women, and we are so excited to start this project. So it's going to be an educational app for pregnant and postpartum women with OUD. It's going to provide low literacy education on OUD, NAS, and then the different components I had mentioned. We are going to include mental health. There's going to be prenatal information, postnatal information. We've got 6 or 7 different categories, I feel like, with each topic. I think there's 10 topics, but there will be 20 videos the first year. So we're not just going to put out an app with a whole bunch of written content. The content will be in video format, so the women can easily watch a 1 to 2 minute video. Once they watch the video, actually, let me back up a little bit. There's going to be a pre and post test with each video. So women will take a pre-test, watch a video, take a post test. They will earn badges for watching the different videos and as they answer questions correctly. In order to develop this, we have formed 2 advisory committees. One is a professional advisory committee, and some of you who are on the call are in this committee. Currently, we have 17 professionals throughout Allen County serving on our professional advisory group. And then we are developing a second group, a moms group, of some of the women from the original report that we completed. But we're also getting suggestions from Dr. Sarah Turner, and some local recovery organizations have women who want to participate as well. So as we develop content, the professional advisory group is going to be reviewing it, providing suggestions, but we're also going to take that content to the women to review and provide suggestions, because Macmillan Health is not subject matter experts in these things. We are relying on the professionals who are to help guide this, but we're also relying on the women who are living this day in and day out to provide their input, because ultimately we want their input. We want them to use this and find this useful. We don't just want to create something and we're like, we think this is going to be wonderful, here you go, and then it not prove beneficial to the women. So we have the 2 advisory groups. I went over in her words how it's going. We've held our first professional advisory group last week. Actually, we did 2 advisory groups last week. Because there are so many professionals, we want to give them each opportunities to share information with us while they're on these calls. So we actually broke that down into 2 meetings, and it actually worked out beautifully because we had a lot of feedback from all of the professionals that I don't think we would have had all of them been in the room at once. Our goal is to start piloting the app in October. So content will be developed beginning, we've gotten the topic areas, we're starting to do the research. The goal is to start putting all of the content onto the app between June, July, and August, working out all of the technical things, and then starting that pilot October 1. And then we're hoping that this becomes a larger project than just serving pregnant or recently pregnant women with OUD and their babies being born with NAS. Our goal is to make this a 5-year project where it becomes a prenatal, postnatal app. So this year, the next 18 months, although we're focusing on OUD and NAS, our goal is to be able to expand that into year 2 to focus on prenatal care and safe sleep, tobacco use during pregnancy, and then nutrition in pregnancy. And there may be additional topics added, but that is our ultimate goal, is to make this a comprehensive prenatal, postnatal app, a one-stop shop for women to collect information, educational information in a low literacy, heavy video content format. The second part of this app is that professionals are going to have a login portal, and the women using the app can authorize professionals to view their progress. So although we're developing this, the goal is to ultimately link these women with a home visiting organization and make sure that the physicians are aware that this app exists. And then the physicians and home visitors and professionals working with these women can check their progress. So it may be something where a home visitor is like, hey, you know, before I see you next, I'd really love you to watch these 2 videos on mental health. I really think that they could help you. The professional will then, if given authorization by the woman, be able to check that progress. Another component of the app will be a chat feature, and that will be part of phase 2. The app is being developed in 2 phases. Phase 1 is content development. Phase 2 will include that professional portal as well as the chat feature. One of the largest things that we heard from the women from the initial report is that when they would go out to traditional apps or you know, chat rooms to ask other women about opioid use disorder, they would be shamed or often spoken down to. Even by those serving them, this often happened. So really these women felt isolated and that they had no one to connect to and no one to talk to. Phase 2 will include a chat room where the women can interact with each other. It will be moderated. We will be reviewing that daily. And the reason that it's going into phase 2 is we have to make sure it's HIPAA compliant, because some of the information the women share may include HIPAA information that must be protected. But it will give them a safe environment to be able to communicate with each other. We are trying to determine whether or not that will have a direct messaging feature or how the women could connect outside of that chat feature. But since that was one of the biggest things that we heard from that initial report, we wanted to at least give them an environment where they could ask questions of one another. So that's a very quick overview of this project. It's been in the works, like I said, since 2018. Content's being developed as early as today. We're really excited about the opportunity to share this. It will be piloted here in Allen County. Our goal is to reach at least 300 women over the initial 18 months and 25 professionals serving those women. So again, the professionals could be home visitors, physicians. This app will be free and downloadable from Apple as well as Google Play. So although we're targeting Allen County, the app will be available nationally or globally, I guess. But we are really going to push in the initial welcome videos. The goal is to get linked with the home visitor. We don't want this to serve as a standalone educational resource. We will also be developing a facilitator guide for the professionals serving these women, so that way they have a guide to be able to start the conversation. If a home visitor is going in to see a woman and maybe they think that there may be substance use disorder or opioid use occurring, it will provide a guide to be able to start that conversation. So it's going to include motivational interviewing questions, but also just that information that we heard from the physicians and professionals serving these women, that they have nothing. They have nothing to give their staff to offer as a resource, you know, other than Google. So this will just be a digital offering that professionals can use to be able to correlate and guide them along their journey with these women using the app. Very fast overview. Any questions?
We've got a couple questions in the chat for you.
Yeah.
Kelly has put in there, Kelly Cunningham asks, are there plans to expand beyond opioids into other substances?
So yeah, so we've heard tobacco usage, we're hoping will be a standalone year, but we are going to include tobacco use and alcohol use within opioids, because what we found in the initial interviews is that these women were using multiple things at once. They almost all, I want to say like 98% were also using tobacco, at least about 60% tobacco or alcohol. So we know that there's multiple substances being used. The just main focus will be opioids.
A second kind of a comment in there from Shepherd's Hand is, how can an organization be kept in the loop as this app becomes available to the public?
Yeah. So as we develop content and it becomes available, we will do a mass media campaign, and we're hoping at least we'll be able to share it with local news outlets. But if you guys you can be added to our newsletter. We've recently started a quarterly newsletter at Macmillan. I know you guys are probably thinking newsletters are kind of, do people still do those? That's one of the things we were wondering. We've actually just restarted a digital newsletter. So if you want to be added to that, you can either email me directly or put your email in the chat feature. I can look for it and then add you guys to our quarterly newsletter, and that will be pushed out. We'll do social media postings. We will be reaching out to organizations as well who are specifically serving these women. So if that's you, definitely let us know so we include you on any media campaigns that we are doing. And we're hoping the local news will at least pick up some as well.
And we'll be happy to be pushing this information out to everybody in the prenatal and infant care network who's on this group and beyond to help reinforce what's coming out. And then there's one more question is there a focus on cultural competency and diversity in the video content?
Yes. So that's one of the biggest things. So I don't know if you guys are familiar. Most of us just associate us with sex education. We do a lot more than sex education. We've really expanded. We still do our traditional preventive health education programs. We offer over 100 health education programs, not just sex and drugs, but we also develop media and content for other organizations. So one of the things that we've really been trying to do when working with clients and that they're saying to us as well is really diversify what you're giving us, diversify the images, diversify the video individuals that you're using in the video. So one of our biggest goals with this project is working with the women that we interviewed and who are going to be part of the moms group to at least get some of the individual interviews that we will be conducting with them as recordings, and they will be used with voiceover. So the moms are not necessarily comfortable being on video, but will be able to use their voice with a voiceover. Our goal is to definitely show the diversity, though, of these women. Although you may not be able to see them, you'll hear them. And we want to make sure that we are being very inclusive of all individuals.
Wonderful. Well, Nicole, thank you to you and your team over there for moving this great project forward. And I know there's many on the call helping to support you in different ways. So thank you very much.
Thank you.
I'm going to turn over the last word to Laura Dwire and thank her for putting together this good program today. And Laura, you get the last word.
Oh, wow. So I want to start by thanking all the speakers today. What amazing recommendations. We have so much work to do, especially around mental health and substance abuse or substance use disorder. I do want to encourage everyone, because we didn't have the time to do introductions, to please look at the chat box. There's a lot of events that are in there. There's a lot of new members that have put some links in there as well. So I do encourage you to just look at that before we sign off. And that's really it. I do always end with thanking you for all the work you do. We all have a vested interest in having healthy and happy families in our community. And I just implore you to keep up the good work. Our next webinar is scheduled for Thursday, May 20th. And again, that's tentatively around the sleep safely and safe sleep education and the data that we collect. So thank you again. Sorry you went just over a little bit, but glad to see you all, and keep safe.